All right, hi everyone. This is my advanced studies presentation. So I looked at statin prescription patterns in the Southern Adelaide population. Um, let's get straight into it. So this was a project undertaken as part of my advanced studies, as part of my medical degree, with the help of Richard Woodman. So he actually helped a lot with this. So I'd like to thank him as well for this. Um, so this project was completed over the span of 3 years. Set of de-identified emissions data from FMC over 2012 to 2014. So as an introduction, statins are a drug class which has been shown to lower lower density lipoprotein cholesterol, or LDLC, which is one of the major modifiable risk factors for developing coronary heart disease. So it's currently several statins are recommended in guidelines for preventing heart disease, and these include atorvastatin, rosuvastatin, and simvastatin. So the first goal of my project was to establish whether there's a prescription pattern of these statins in the Southern Adelaide population. And it's also been known that morbidity and mortality from heart disease is greater, or the greatest, in lower socioeconomic groups. Studies in other countries have been performed to determine if there is a relationship between socioeconomic class and statin use, and it's been found that lower socioeconomic classes have a lower rate of statin prescription. But no study has been done to show if this trend is true for Australia, particularly given that we have the PBS scheme, which allows for more affordable medications. So this project also aimed to establish if there was any relationship between socioeconomic class and statin use in the Southern Adelaide population. So with these two, I'm going to talk about these two goals separately. So I'll talk about the methods I used to achieve each goal and the results, and then discussing each of these two goals separately. So just a little bit about the study. So as I said, the objectives investigate the prescription pattern of commonly prescribed statins in the Southern Adelaide population over time to determine any associations between the statin usage and socioeconomic status. This is a cross-sectional study using the de-identified admissions data from Flinders Medical Centre from the period 2012 to 2014. It involves the Southern Adelaide population, and the outcome measures is the yearly prescription rate of each statin for my first goal, and for my second goal was the statin usage rate per 1,000 for each socioeconomic status quintile. Okay, so I'm going to talk about the statin prescription trend. So the methods I use for this, so as I said, the data was taken from a 3-year de-identified data set of admissions taken from an OASIS database at Flinders Medical Centre. This was a data set I received from Richard. This 3-year data set contained information on patient demographics, medications, diagnosis in the ICD-10 codes, and prescription records. So multiple diagnoses for each patient were listed as multiple ICD-10 codes, and each patient had 25 possible diagnosis variables, coded as Diag 1, Diag 2, etc. So this allowed for multiple diagnoses for each patient. So you can see here in this example, patient number 1, he has, you can see there's 3 diagnoses coded in these ICD-10 codes. So you'd have to look up these ICD-10 codes to know what diagnosis this patient 1 had, and etc. You can go down the list. This is patient 2 with these 2 diagnoses, etc. And then each patient also had 21 binary variables which are coded to indicate if they were using a certain class of medication. So for example, class 1 drugs here. So this is the first patient. The class 1 drugs were coded as proton pump inhibitor drugs. So you can see 0 means this patient wasn't taking proton pump inhibitor drugs. My project was interested in class 11 drugs, which are statins. So class 11 drugs were statins. So you can see this patient here is taking a statin. It's coded as 1. The binary variable for class 11 is 1. And you can see down the list, this patient isn't taking a statin. These 2 aren't. These 2 patients are taking a statin. Okay. So then the de-identified dataset also contained a variable, a descriptive word variable called word1, which told me the exact medication that each patient was taking. So for example, you can see here, patient number 1 was taking perindopril, patient number 2 is taking bisoprolol. Okay, so what I did was I could create a variable for atorvastatin users using this simple code, word1 equals atorvastatin, and then I could do the same for the other types of statin. So you can see the coding I used, the example here. So I generated a new variable, atorvastatin equals 1, if word1 equals atorvastatin, and then same thing for fluvastatin, pravastatin, rosuvastatin, simvastatin. So I could generate variables to see how many people were taking these statins. Okay, so these are the results. As you can see, this is the tabulated data set. Atorvastatin by far was the most taken statin, 59%, and quite consistent over the 3 years. And then I've graphed it as well for you guys to have a look. Atorvastatin, as you can see clearly, it's quite a consistent trend over the 3 years. It's by far the most popular statin. This is followed by rosuvastatin, and then simvastatin. Fluvastatin and pravastatin are quite low, quite rarely prescribed, as you can see from the numbers. And this is the coding I used to make this graph on Stata. So we'll talk a bit about the result. So as you can see from the previous slide, atorvastatin was the highest prescribed statin in all 3 years of the study. In the Australian therapeutic guidelines, a high-intensity statin is recommended for both primary and secondary prevention of cardiovascular events. So these high-intensity statins include atorvastatin, rosuvastatin, and simvastatin. And it's also common practice to switch between statins if side effects occur. So as you can see from the data, atorvastatin is the highest prescribed drug, highest prescribed statin. So it can be inferred from this data that atorvastatin is the preferred statin for most clinicians. The trend for atorvastatin being the most commonly prescribed statin, followed by simvastatin, is in line with other countries, as shown by other studies. This popularity has been attributed to a couple of reasons. Favorable research results for atorvastatin, and also certain marketing strategies from pharmaceutical companies, which have also helped atorvastatin be the most popular statin on the market. And I suppose the results that I've found in the Southern Adelaide population do match up with the results found in other countries. Just having a look at some other studies done, because I just wanted to sort of understand if this prescription pattern of atorvastatin being the most prescribed statin was appropriate. So these other studies have shown that rosuvastatin is more effective in lowering LDL levels compared to atorvastatin at the same dosage. This was a study done in 2008. Another study showed that there could be some variability in LDL lowering response between atorvastatin, rosuvastatin, and simvastatin, depending on the individual patient. This is a study done in 2003. These results suggest that there could be an overprescription of atorvastatin in the Flinders Medical Centre patient population, as atorvastatin is clearly the most prescribed statin, but the research does not show that atorvastatin is clearly the most effective in lowering LDL levels, or clearly the most effective statin. So there's a bit of discrepancy there. Further study could be done to look at the LDL lowering efficacy of these 3 statins in the Australian population to see if the rate of atorvastatin prescription, this high rate of atorvastatin prescription, is justified. So the second goal for my project was to look at socioeconomic status and statin usage. So the methods I used for this project, or this goal, first of all, I had to calculate the socioeconomic decile for each patient. What I did was I took the socioeconomic index for areas 2011, or the CIFA score for each subject. So this was a separate data set which I took from the Australian government website. It came as an Excel document which I converted into a Stata data set. So as you can see, this is the original document from the government website, the CIFA 2011. You can see that there's each suburb listed here, and it's got a score for socioeconomic score, and then the relative socioeconomic decile. So you can see one would be the lowest decile and 10 would be the highest. So according to this, the suburb Aldgate has decile 10, so it's quite a privileged suburb. So what I did was, first of all, with this data set, I kept if it was a South Australian postcode. Okay, so that's the coding. And then I merged this CIFA 2011 dataset with the Oasis dataset using this code. So what I did, as you can see, I merged it. This is the original dataset. It's had the suburbs, and I've merged it with this CIFA 2011 dataset. And now each patient has a socioeconomic decile based on their suburb. And yeah, so now each patient had a socioeconomic decile based on their suburbs. We could see, sort of get an indication for the socioeconomic status of each patient. So then the results I've got, I tabulated the socio group and the class 11 users, because remember, class 11 users are the statin users. So this is the coding, quite simple. I also sorted each the patients into socioeconomic quintiles, 1, 2, 3, 4, 5, 1 being the lowest, 5 being the highest, according to this coding. So the socio group equals 1 if decile is lower than 3, socio group equals 5 if decile is higher than 8, and you can see all the in-betweens. Okay, so you can see clearly that there is a trend. The socioeconomic quintile, quintile number 1 had the highest rate of statin usage per 1,000 users, whereas socioeconomic quintile 5 was lower, and you can see it generally trends down. So basically the results of this study show that the lower the socioeconomic quintile, the higher rate of statin usage. And then you can see as another component of my research, I also mapped out socioeconomic decile and statin usage using an SPMaps function in Stata. So what I did was I took the map coordinates for the South Adelaide region, which I obtained from the South Australia government directory, and this data was changed to a Stata dataset format. So you can see this is the coordinates for the Southern Adelaide region, which I took from the government directory, and then I merged this dataset with the Oasis dataset so that each patient had some coordinates, if you could say, for the suburb of residence. And after that, I could generate a geospatial map using the SPMaps function. So you can see these are the results. First one is a map of socioeconomic decile in the Southern Adelaide region. So you can see this is the coding I use, SPMap, the decile score using the coordinates for each patient. So you can see here, it might be a bit hard to see, but here's a legend. So the higher deciles were coded in dark blue, the lower deciles were coded in sort of a pale white, pale blue, pale white color. So these areas are high socioeconomic status. These areas here were lower, more pale, or lower socioeconomic groups. So this figure here is statin usage in Southern Adelaide. So very similar code, SPMap, frequency of usage using the coordinates. So again, higher frequency of statin usage is darker, lower frequency is paler blue. So high usage in these areas and lower usage here. And this one here, I suppose, is a more important measure. It's the statin usage rate. Okay, so the statin users per suburb divided by the admissions per suburb. So it's the SP map rate using the coordinates. So you can see these pockets, these suburbs here have high relative rate of statin usage. These areas have lower rates. So what was useful about this this exercise is you can sort of visually compare what areas, you can visually compare the socioeconomic status with the rate of statin usage. So as I said before, you can clearly see that these areas here have high socioeconomic status, these three pockets, and you can clearly see that these three areas have relatively lower rates of statin usage. Then you can see in areas, higher areas of statin usage, perhaps such as here, so you can see in the darker shades of blue, you can compare it to the socioeconomic status of the people living here on this map. You can see it's quite pale colored blue, quite light colored, which suggests the socioeconomic decile is lower. So this is just a visual representation of the results I found before, which you can see that the lower socioeconomic groups, quintile 1, had the highest rate of statin usage, and the highest quintile had a lower rate of statin usage. So I'm going to discuss this trend now. This was actually quite a surprising result, given that previous studies done in the other population groups in other countries had shown the opposite trend. So in other countries, studies have shown an increased rate of statin usage in higher socioeconomic groups. Even an Australian study done in 2004, looking at the wider Australian population, the trend has generally been a higher rate of statin usage in higher socioeconomic groups. The reasons postulated for this include generally a higher health literacy in these higher socioeconomic groups. They also have a higher expectation for the current and future health, given the prophylactic nature of statins. And these higher socioeconomic groups tend to have more consultations and longer consultations with their GPs, which gives them more time for preventative activities like statin prescriptions. So I did some further investigating because this was quite a surprising trend. So I looked at I wanted to look at the rate of heart disease in these lower socioeconomic groups, because it would make sense for lower socioeconomic groups to be prescribed more statins if they had higher rates of heart disease. And again, I looked at, this is the coding I used. So remember I talked about the ICD-10 codes. Ischemic heart disease is coded as I-20, so I could count the number of ischemic heart disease patients and then a tabulated socio group with ischemic heart disease. And you can see clearly the rates per 1,000 is the highest in this lower socioeconomic quintile and goes down again. So the higher socioeconomic quintile has the lowest rate of ischemic heart disease. So logically, this would explain the higher rates of statin use, but as I said before, this finding of higher heart disease rates in lower socioeconomic groups is also consistent with other countries, so it doesn't really fully explain the higher rates of statin usage in the lower socioeconomic groups in southern Adelaide. So there are a couple of theories that I postulated to explain my findings. Number one, could be a small population in my study. I'm only using the FMC admissions data. So it could be inferred that this population is very well looked after by their local GPs, because they, what I'm trying to say is that they have higher rates of ischemic heart disease, but they're all appropriately prescribed statins, suggesting they're very well looked after by the GP. And perhaps this level of care does not extend to the wider population, which explains why the trend I found goes against previous studies. The other theory I suggested was due to limitations in the dataset, and I believe this is a more likely explanation, as I only examined hospital admissions data, and members of the population who were on statins but not admitted to hospital for any reason were excluded from the study. Due to this, there might be an overrepresentation of lower socioeconomic statin users in the study, This is supported by there being more data in the lower socioeconomic groups. Decile 3 and 4 were the highest represented groups in the study. Studies have shown that lower socioeconomic patients tend to overuse acute hospital care. They tend to prefer hospital admissions or ED presentations over going to primary care or going to their GP. And so as a result, there may be an overrepresentation of these lower socioeconomic groups in the study I performed. So further study could be done to examine a more complete population in the southern Adelaide region. So the limitations of my study included the data set only capturing a 3-year period. The second limitation was that the main measure of socioeconomic status was only a suburb of residence based on the 2011 CIFA I merged with the data set. Things like education, income, and type of occupation were not measured. And the data set only included Flinders Hospital admissions, didn't include the Noarlunga Hospital or the GP patient data. This is particularly important as statins are mainly prescribed in the primary care setting or with GPs. So lacking this data, I believe, did skew the results quite a bit. So in conclusion, the two major conclusions, the majority of statin users were prescribed on atorvastatin, rosuvastatin, and simvastatin were prescribed at much lower rates. And as I said previously, the appropriateness of this prescription pattern needs further investigation. Second conclusion, lower socioeconomic groups had higher rates of statin usage. This is likely due to the patient population that was studied, as there was only a hospital population. Further research into a wider population, particularly GP patients, should be conducted to further investigate this. This is particularly important as statins are primarily prescribed in the primary care setting. And these are references I used in my presentation. So thank you for listening to my talk. Once again, I'd like to thank Richard Woodman for helping me over the past few years for my advanced studies project. I definitely couldn't have done this without him. So thanks, and I hope you guys all enjoyed my presentation.